Well, greetings, everyone, and welcome to the March 2015 EMedHome EMCast. My name is Amal Mattu, and we have a great show for you once again this month. Before we get into it, I just wanted to put in one reminder and one plug, or maybe two plugs. First of all, don't forget about the Resuscitation Conference coming up in Las Vegas, May 1st through May 3rd at the Wynn and Encore Hotel. Check out the website, www.resuscitation-conference.com. And secondly, I wanted to send some props out to an emergency physician by the name of Dr. Bernard Riberty. My family and I were up in Breckenridge for a very nice little conference and family trip, and on the second day, late on the first day, my younger son developed a little bit of altitude illness, and I took him into one of the local clinics up there and was seen by Dr. Riberty, and I just wanted to send thanks to him and props to him. What a great emergency physician. He was incredibly smart. He was funny. He kept Cameron entertained through the treatment and just had wonderful, amazing bedside manner. If anybody out there knows him, give him a pat on the back. He's one of us in the field, and it was just so nice to see an emergency physician up there who has great bedside manner and really knew what he was talking about. And I think he's representative of so many great people who don't get enough credit for what they do. So, Dr. Riberty, thanks for what you did for my son. We had a great time starting the next day when he was back up on the slopes. And again, thanks so much. So, back to the EMedHome EMCast. This month, we've got three topics to talk about. We're going to spend some time talking about the new 2014 ACC, AHA, HRS. HRS is Heart Rhythm Society, in case you didn't know that there was such a society. Atrial fibrillation guidelines. Now, most of this is written for cardiologists and primary care docs, but some of this is very relevant to us in the emergency department. We're going to pick out some of the key pearls that we all need to know in our emergency department practice from these national guidelines. Secondly, we're going to talk about alcohol withdrawal and delirium tremens. This is based on a New England Journal of Medicine review article that was published in November. Dr. Michael Bond is going to take us through that article, and we're going to finish things up by going back to OBGYN, which we haven't done in quite some time. But Dr. Priya Kupusamy, who is one of our former graduates and now an attending at a community hospital, is going to spend some time talking about pre-eclampsia. Her area of particular academic interest is OBGYN. She studies this stuff inside and out. And there's some updates in terms of pre-eclampsia, diagnosis, and treatment that we all need to know. So with that, we are going to go ahead and get started. Okay, well, we're going to kick things off with a discussion of the new ACC, AHA, Heart Rhythm Society guidelines for the management of patients with atrial fibrillation. And back with me is our local emergency cardiology expert and the head of our emergency cardiology fellowship, Dr. Samara Tuweld.
I do like other topics in emergency medicine too.
No,
it's just my favorite.
You do not. You do not. Everything turns into cardiology cases with you. What was the last case you told me about? A person came in complaining of
vomiting
vertigo, and then turned into like a ruptured AAA or something like that, right?
It's all related to the heart. You know, when they say it's the lungs, it's not. It's really the heart.
Well, I'm not going to argue with you about that. Have you seen any atrial fibrillation in the past month?
Oh, unfortunately, I've seen it too much, and I've seen colleagues shocking it in the ED, shocking it. I don't know. I was very uncomfortable. We don't have a protocol here, and I'm wondering if we should get one because I think it's in vogue right now. And so we need to be clear on the new updates, especially.
Yeah, shocking AFib. So anyway, well, maybe this will provide a little bit of clarity that not long ago, just I guess again a couple of months ago, the American Heart Association and American College of Cardiology and the Heart Rhythm Society put out the new 2014 guidelines for management of patients with atrial fibrillation. And of note, the last time they put out a full set of guidelines on AFib, believe it or not, was 2006.
Yep.
Since then, they have put out a couple of focused updates which really intended to just update people on all the new anticoagulants. But in terms of, and probably they were all funded by drug companies pushing those things. But anyway, in terms of a full update on atrial fibrillation, it's been more than 8 years now, so it's nice to see this. This was a pretty good set of guidelines. A lot of this is clearly more directed towards inpatient physicians and also outpatient physicians, but there is a handful of things that are very relevant to us in the emergency department, and Samara is going to help us get through that. So first off, let's just talk about the key features that are relevant to us instead of all the details here. But first off, they talk about decisions about anticoagulants, not necessarily the specific anticoagulants, Coumadin versus dabigatran versus rivaroxaban or all those, but simply I think they make an important point that we in the emergency department have a key role in deciding as to whether patients with new onset atrial fibrillation or flutter, and by the way, these guidelines apply to flutter also, should be started on anticoagulant therapy or not. They talk about scoring systems, and again, I always go back to my residency and think that everybody with new onset AFib, we would anticoagulate everybody.
And it's not harmless, right? Like anticoagulation is not necessarily great.
So tell us a little bit about which patients we should be anticoagulating.
Certainly. So I think formally we heard a lot about the CHAD score, and I think they've basically updated it. So if you haven't heard the CHADS VASC score, it has some twos in there, so we'll go over what all these things mean. So it's an acronym, and so it stands for, basically you're using the scoring system to determine who requires or who you should at least start on anticoagulation, and if they need it at all. So the CHADS score specifically stands the C for congestive heart failure, the H for hypertension, the A for age, and that's an age greater than 75 for the first age, the D for diabetes, the S for stroke, and this means stroke or TIA, and you get 2 points for that. And then the VASC part of that will be the vascular disease. So have they had a prior MI? Do they have peripheral arterial disease or aortic plaques that they know about? Age again, so this is a lower age cutoff, 65 to 74. The first age gets 2 points, and the second one is lower, gets 1 point. Sex category, female, and then that's it. So that's CHADS VASC. So when you talk about this scoring system, it goes to a max of 9, and a person that's obviously 0, that's coming in with AFib, so maybe the person, has no risk whatsoever, you don't need to anticoagulate them. If they have 1, that's when you say, okay, does this person need aspirin? Some people qualm about whether 1 should be anticoagulated with other agents, but I think that for 1, aspirin is not harmful, and it's something that's safe, and I would say that's what most of us are doing. Greater than 2 is when you're going to consider now these other agents, such as warfarin.
2 or greater is when you start getting into the real anticoagulants.
Yep.
Okay.
So options include warfarin and all these new bad boys, I would say.
All right. Okay, so just to recap, the CHADS VASC score has taken over what used to be the popular CHAD score. So what does CHADS VASC stand for? It's CHADS and then VASC, and we'll put what all those things stand for in the show notes. But my recommendation is don't even bother trying to memorize this. Just go to your computer and do a Google search on CHADS VASC, and you'll come up with scoring systems, and you just punch in what are the applicable items for your patient, and it'll calculate the score for you. Generally speaking, if the score is 0, anticoagulation is not recommended. If the score is 1, most recommendations are to just give aspirin, and if the score is 2 or more, then those are the patients that get full anticoagulation. Now, I will tell you that since this was recorded with Samara just a couple of months ago, I've seen 2 articles come out that have been specifically talking about the CHADS VASC score of 1. One of the articles said that we should be giving full anticoagulation, and the other article said that if the score is 1, don't give anything. So there is still significant controversy regarding what to do with the score of 1, and as far as I'm concerned, if I see a score of 1, then I'm just going to use aspirin and maybe coordinate the future care plan with their cardiologist or the primary care physician. Well, there's a lot of choices of new bad boys. It seems like warfarin still seems to be the default medication for most conditions.
Yes.
And you can always discuss with the admitting docs or outpatient docs us which preferences they have, and we won't get into the details of choosing one anticoagulant versus another. But there's a lot more debate in emergency medicine about rate and rhythm control. Rate control still seems to be the most popular approach to new onset rapid AFib in the emergency department. So let's talk about rate control first. So if a patient shows up on your next shift, which no doubt that will happen knowing the black cloud that you have, with new onset rapid AFib, what are the options and preferences for lowering the rate? What do you do? How do you decide? What are the options out there?
Right. So the first thing is the patient hemodynamically stable or unstable, right? So you can have a rate of 150, 160, even 180 in some people, and they're hemodynamically stable. So I would say that's when you're going to consider medications. However, if they're unstable in any way, meaning hypotensive, having ischemic changes on their ECG, pulmonary edema, or altered mental status, any of those things, you should be cardioverting them.
Sure.
That being said, when they are stable, when you're using pharmacological agents, as long as the person does not have pre-excitation, I think that's the big thing throughout this whole updated guideline that they talk about everywhere. Pre-excitation, or WPW as we call it. The agents for rate control are very different when you have pre-excitation versus not. So this applies to your all-comer that does not have pre-excitation. First line, I would say, is beta blocker or calcium channel blocker. And that's what you're using. Now, when you have people that are resistant to this, or you have a known history of heart failure with a reduced EF or decompensation, that's when you're going to consider amiodarone or digoxin. All of these agents that I just said are all AV nodal blockers in some way, so beta blockers, calcium channel blockers, amiodarone, and digoxin. And with anyone with pre-excitation, if you use any of these agents, you're going to worsen the rate, and you could cause them to basically arrest.
Sure. It seems like in emergency medicine there's a general preference to calcium channel blockers, whereas in cardiology there's a general preference to beta blockers. This wasn't really discussed specifically in the article. They just said beta blockers or calcium channel blockers, equal rating. Do you have a preference, just out of curiosity?
I think that I found that calcium channel blockers do work better in patients, and I think that you have to wonder, are these patients already on beta blockers, in which case you may not want to block both beta pathway and the calcium pathway. So in a person that's on beta blockers, maybe hasn't taken them, or just is on them for blood pressure control, has a history of something else, diabetes, use a beta blocker, I would say. That being said, a person who's never had AFib before and coming in pretty fast rate, I'm going to use a calcium channel blocker as long as their blood pressure can handle it, because it is going to be more hemodynamically affecting than your beta blocker, which is typically a pure beta 1 selective agent.
Sure. Well, that's a great approach. So if somebody's on a beta blocker, just give them a beta blocker. If somebody's on a calcium channel blocker, I guess just go with the calcium channel blocker. If they're on neither, then maybe a slight preference to calcium channel blockers. And if they are tenuous or have a low EF, then maybe there's a little more evidence suggesting beta blockers might be a bit better.
If you're Canadian, maybe give MAG.
Is that preferred in Canada?
I've read some studies, some Canadian studies that say that it helps for AFib. So.
All right. Well, why not?
Yeah.
No harm, and most everybody who's a cardiac patient, especially if they're on diuretics, is hypomag to start with anyway. And most elderly, it seems, are hypomag as well, maybe because a lot of them are on diuretics. So that's an important point. Okay, now you alluded to the unstable patient. Clearly, if somebody's got rapid AFib and they're unstable, then you just follow ACLS and you're going to try to shock them.
Yep.
All right? For rhythm control. And if you cardiovert them, then that's kind of that's going to rate control them also.
Yep.
But pure rhythm control is becoming more common in many emergency departments, even if patients are stable. And again, we've got colleagues who have wanted to do it, although we don't actually have a protocol here for doing that. There's increasing literature about cardioverting patients with electricity or with medications. And you brought up Canada. Canada seems to be all over this, and they've published some really good data on rhythm control using things like procainamide or cardioversion. The data looks really great, and it's certainly within the standard of care to do that. If you did choose rhythm control, what are the recommendations, or who are the appropriate candidates? And that's a question that I'm going to pose to you for both electrical cardioversion and also chemical cardioversion.
Certainly. So I think first thing to consider is, do you have a patient who you're trying to discharge immediately from your ED? You should be asking yourself, or is this a person that you're trying to watch under into the observation unit or even admit. Because when you talk about pharmacological cardioversion, you're not giving drugs that have effects, including pro-arrhythmic effects. So if you're going to be cardioverting them and using these agents, I think you should be watching them for longer, as opposed to obviously giving them some sedation and then directly just electrically cardioverting them. So I think that's the first question. And then also, how long have they been in their AFib? So obviously we're talking about people with a good history that can say exactly when they had the onset, typically less than 48 hours. And usually these people are young, healthier people. Now, there is some studies that show in people that have, high risk of having a stroke that then also can tell you it started, hey, today at 5 o'clock and it's now 8 o'clock, so a very short duration. You may want to consider giving them anticoagulation like heparin or Lovenox and also cardioverting them, because their risk of stroke is very high. Mm-hmm. So we're talking about people that have been in AFib for a very short period of time, and we want to either, again, electrically or pharmacologically do it. But with the pharmacological therapies, there's a lot more risks, being pro-arrhythmic specifically and altering your QT. So I would say, that's something to watch out for. And those people, I think, do warrant, from my opinion, a little bit more monitoring than the person that you just, once they get shocked, or I should say cardioverted, they're out of the rhythm, and then, there's not much else to do. They need to follow up. They can go back into AFib.
So generally speaking, these are definitely going to be people where you're pretty certain it is less than 48 hours of onset, and the younger patients without any significant comorbidities tend to be better off. You're not just going to quickly cardiovert them and send them out the door. They should be obsed, and I think even in some of the Canadian studies, they talk about a 6 to 8 hour period of obst to make sure they don't go back into it, because it's no good to shock somebody or cardiovert them and send them out, and then as soon as they get out to their parking lot in the car, they're back in it already. So there's usually a short period of observation there, and then the other thing is that there should be some close follow-up with those patients. And that's one of the reasons why in our population we really haven't succeeded in putting a protocol together.
Especially when you're cardioverting these people, you need to consider whether, again, electrically or pharmacologically, you need to still, with the electricity, you're going to be getting moderate sedation. Obviously, you're not going to just cardioverт them and not give them pain control. You need to have informed consent. They need to understand, although the risk is very low, it's not zero, the risk of stroke even within less than 48 hours. So you should be having an informed conversation, and it should be a patient and a physician-provider conversation. A dual decision should be made. Risk-benefit should be weighed, and all this should be documented before you decide either one. When we talk about the pharmacological agents, because of the abnormalities and the ability to go back into AFib, this guideline does specifically talk about even sending them home with one of the 1C agents. So they call it the pill in the pocket. When you hear about propafenone or flecainide, these are the pharmacological agents that they use typically for pharmacological cardioversion. You have the 1C agents and you have the class 3 agents when we're talking about the antiarrhythmic classes. So the options you have, and it's laid out in this guideline, is amiodarone, dronedarone, dofetilide. All of those are class 3 agents, and then the class 1C agents, typically flecainide and propafenone. So they even, once you convert them in the ED possibly or in your OBS unit, they even go home with a dose of propafenone or flecainide in addition to a beta blocker or calcium channel blocker, so that if they go back into this rhythm in the next couple of days, they can take a pill, which, is pretty cavalier to me. I mean, you as an ED doc are giving these meds, so you have to be very careful and make them aware that they could have pro-arrhythmic effects. They could get worse and they need to go to their closest ED.
Yeah. I was a bit disappointed that they really didn't talk about procainamide for rhythm control so much in this. And in fact, they didn't really get into any specific protocols for pharmacologic or electrical cardioversion. They just said it's an option, but they didn't really tell you how to do it. So maybe on a different podcast we can actually talk about that actual process and talk about the procainamide protocol that has been published from out of Canada at some point in the future. But it is becoming more popular to cardiovert these patients with new, less than 48-hour rapid AFib, and certainly within the standard of care, and patients seem to be doing well. So we'll talk more about that in a different segment. Most of the rest of the guidelines are written for further inpatient and outpatient management, but there's just a couple more issues that are relevant to ED care that I wanted to ask you about. Specifically, they talk about some of the special patient populations, and I want to ask you about just a couple of them. First of all, AFib plus WPW, you alluded to earlier. What do we need to do differently with that group of patients?
So that group of patients specifically, if they're unstable, you need to cardiovert them. When they are stable and you want to slow the rate, the options that you have are IV procainamide, so that's a 1A agent, antiarrhythmic, and ibutylide, which is a class 3, and those are the potassium blockers. That being said, ibutylide is allowed to be used and not amiodarone, which is also a class 3 agent, so no amiodarone. So it's not specific to the class, it's which phase of the cardiac cycle that it's actually affecting. Ibutylide is only affecting phase 3, whereas amiodarone is affecting phase 1, 2, and 3, and that's why it's AV nodal blocking and bad for these accessory pathways. So either procainamide or ibutylide are the 2 recommended treatments.
Sure, and that's a big change because a lot of people have promoted amiodarone, but there's a lot of literature actually, there's a bunch of case reports that have suggested that amiodarone can be dangerous. So you stay away from all AV nodal blockers, DH calcium channel blockers, beta blockers, and amio.
And adenosine.
And adenosine, good point.
Yep.
With AFib and pre-excitation. All right. The second group of patients I want to ask you about is heart failure. If you got a patient with rapid AFib who comes in who's got acute heart failure, and let's say that they are relatively hemodynamically stable, what do we do for those patients?
So I think it depends on, number one, do you know if they have a preserved, like how bad is their EF really, and how unstable. So do they have overt pulmonary edema, in which case you really don't want to give like a beta blocker or calcium channel blockers. I think.
Well, let's take both. Let's say that they're stable and they're talking to you, they're giving a history, maybe just a little short of breath and kind of crackly at the bases.
I think in that case, you can give beta blockers or non-dihydropyridine calcium channel blockers. I mean, you need to often it's the rate more so than their baseline CHF or heart failure that's a problem. So in people that are just, a little bit tenuous, not really that bad, give your nodal blockers. In a person who you overtly have problems with, they might be on BiPAP. They have an EF of 10. They have an AICD in, so you're presuming they have an EF of less than 30. Those people you should probably give digoxin to or amiodarone. Digoxin will take a bit longer than your amnio to work, so you just need to give it time. So those I would say would be the 2 most recommended and likely best treatment options.
Sure. So DIG is not gone. DIG is still, and we'll still use it intermittently. I kind of like the idea of when somebody hits the door, just get the DIG on board. Mm-hmm. And you know what? If your other medications work, then no harm done that you gave them DIG already.
Yeah.
It'll go away, and you don't have to keep repeating the dose. But if you get the DIG on board, a lot of these patients, you're kind of working on their heart rate, and an hour goes by, they're still fast, 2 hours, 3 hours go by, they're still going fast. And then you need to start thinking about DIG. Well, you've lost 3 hours. Mm-hmm. If you gave them the DIG right away, that initial dose of DIG and maybe your next dose of DIG might actually be working by now.
Definitely.
So, again, DIG is great because it doesn't drop your blood pressure. It doesn't compromise anything. Mm-hmm. And you really don't have to continue using it if your other things have worked. So it's still a nice option out there, and we don't want to lose options. And then amiodarone is another nice option there because it'll drop your blood pressure a little bit, but not as much as the others.
Certainly.
So,
and
okay.
When we talk about rate control, I think another thing that I've seen residents still doing, maybe not aware of the new literature with the RACE2 trial, but obviously in the ED we use the rate rather. Typically, we want to control their rate, and we're not as worried about rhythm. But how controlling should we be about rate? I think in the initial trial was the AFFIRM trial in 2002, and so that basically showed it's efficacious to be rate controlled, just as efficacious as rhythm, and that's why often we do it in the ED. But the RACE2 trial has now shown that you don't need to have very strict heart rate control, right? You don't need to bring them down to 80 or even less than 100. They can be 110, 110s. That's okay. So you don't have to be as strict on these patients. It's okay to be a little bit more tactical.
Sure. Okay, good. And the last special group of patients that I wanted to ask you about was patients that have rapid AFib and you think it's related to hyperthyroidism. It's not really common, except on the boards, but every now and then you have a patient that you're worried about thyroid storm or thyroid toxicosis. And what do we need to do special for those patients?
I think these patients would be the ones that benefit most from beta blockers. Specifically, I know we use propranolol, and you hear about that, and the reason is because not only is it going to help them symptomatically, but then it's going to stop the conversion of T4 to T3. So you need to remember that that's actually going to help the actual problem with your hyperthyroidism, which is a thyroid synthesis. So when you use the beta blockers, propranolol or esmolol is another go-to for these people. Consider that your go-to. That being said, you have patients with pulmonary disease, and so you hear all this literature with pulmonary disease, don't use beta blockers, and it's really because they have been shown to sometimes preempt bronchospasm, right? So not only is it a beta 1, but it can affect the beta 2 pathway. I think the literature there is more controversial. I think that if they have really bad pulmonary disease, consider not going to a beta blocker for rate control. Consider calcium channel blocker first.
Or if they have active wheezing, then
correct.
Right. But if it's just I've got a history of asthma, or I've got a history of COPD, then I
wouldn't worry about it.
And their lungs are clear, then you're not going to worry about it.
Yep.
And then I guess you could always just go with a beta 1 specific titratable drug like esmolol.
Yep.
And if they start developing any wheezing, you just turn it off and
quick on, quick off. You can just start a different agent.
All right, great. Well, that's a nice review of the key EM elements of these AFib guidelines. We'll have to hook up again to talk a little bit about the actual protocol for cardioverting these patients, because I think that is becoming a more popular approach. And also with Obamacare, we're being told we can't admit patients anymore. We got to send them all home.
Yeah.
We need to figure out how we can do that with these patients also.
Certainly.
All right, thanks
for having me.
All right, well, my thanks to Samara. I think there's some great pearls in there. In terms of what's new, if you've been keeping up with atrial fibrillation literature, I think the new things here, relatively new things, are the CHADS VASC score. It used to be all about the CHADS, but they have revised that. So take a look on the internet for the CHADS VASC score, and the next time you're debating whether you need to anticoagulate your new onset rapid AFib patient, take a look at the CHADS VASC score, and that seems to be the main decision-making tool that people are using nowadays. There's nothing new in terms of cardioverting unstable patients. That's all the same. Calcium channel blockers versus beta blockers, that's unchanged. If you want to use amiodarone or some of these other new drugs for rate control, that's fine. They didn't spend a lot of time talking about rhythm control and cardioversion, but those are still options out there and are becoming more popular options when you're pretty sure that it's new onset. In other words, less than 48 hours ago onset of new atrial fibrillation. And there are some protocols, and hopefully we'll get to those protocols during another podcast. Just a reminder that you don't need to shoot for a target heart rate. If you are using rate control, you don't need a target heart rate of 60 or 70. You can shoot for a target heart rate of, say, 100 to 110, 115 or so. That's perfectly acceptable. The patient should not be unstable if they have a heart rate of 110 or 115 or so. And also the other key thing that we've been talking about forever, but they finally decided to put in the guidelines, is no amiodarone if you are dealing with rapid AFib and WPW. You just might kill the patient. It's now listed as a harmful drug. It should have been harmful all along. All right. So again, thanks to Samara. We'll get her back for some more cardiology talks in the near future. But now, let's move on and spend time talking about another very common and sometimes frustrating condition in the emergency department. All right, well, next up on the EMCast, we're going to spend some time talking about a review article that was published in the New England Journal of Medicine on recognition and management of withdrawal delirium, specifically delirium tremens. The author of this article is Mark Schuchert from San Diego, and a lot of this article is relatively straightforward and basic to anyone out there who works and has been working for a long time in emergency medicine. You and I have seen plenty of DT patients along the way. There are some brief updates about some medications, and that's part of why I wanted to go through this article. And also, a big reason I want to go through this article, even though some of it is going to be, a lot of it's going to be review, is that this is the type of article that very, very often shows up on the LLSA set of readings put out by the American Board of Emergency Medicine. I would not be surprised at all. In fact, I'll bet a little bit of money that this will end up on the LLSA in the coming 1 or 2 years. So let's review it now. Once again, published in New England Journal of Medicine in the November 27th, 2014 issue. Joining us to go through this article is someone that's been on the podcast many times before, Dr. Michael Bond. He's our residency director and associate professor of emergency medicine here at university. So, Michael, welcome back.
Thanks for having me.
Happy New Year.
Same to you.
What do you think about DTs and alcohol withdrawal? Just benzos and you're done, right?
if it was only that simple, I guess the biggest problem that I see is that people aren't really comfortable with giving the huge doses of benzos that we need to give. I think DTs are definitely under-recognized and under-treated most of the time. And the big take-home point is that people need to realize that 1 to 4% of patients are still dying from DTs and alcohol withdrawal, which just seems astronomical to me, considering that we can treat these people pretty easily. But I think people just aren't aggressive at the recognition and management of it. So if we go through some of the stats that the article talks about, alcohol definitely is a big problem in the United States. I mean, people use alcohol as a great argument of why marijuana should be legalized if we have legalized alcohol. But 20% of men and 10% of women will have an alcohol use disorder sometime in their lifetime. And then the article goes through the DSM-5 criteria now for alcohol use disorder, and you only have to have problems in 2 of 11 areas. So just to go through how easy it would be to label yourself as an alcohol use disorder, and this might be some self-reflection time for myself and the listeners.
All right, so everybody needs to listen to these questions, and if you answer yes to any of the following, you need to turn this podcast off and call your doctor and get in to help. Okay, here we go.
Alcohol is often taken in larger amounts over a longer period of time than was intended. There is a persistent desire or unsuccessful effort to cut down or control the alcohol use. A great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effect. You have a craving or a strong desire or urge to use alcohol. Recurrent alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. Continued alcohol use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. Important social, occupational, recreational activities are given up or reduced because of alcohol use. Recurrent alcohol use results in physical hazards. Alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol. Number 10 is tolerance, which is defined as a need for markedly increased amounts of alcohol to achieve intoxication, or a markedly diminished effect when continued use of the same amount of alcohol. And 11 is withdrawal. The characteristic withdrawal symptom for alcohol or alcohol is taken despite or to relieve or avoid withdrawal symptoms. So it really doesn't take a lot of criteria to meet DSM-5 criteria for alcohol use disorder.
All right, so hopefully not too many of you turn the podcast off. For the rest of you that are still listening, we will continue. And you only need 2 out of those 11. Huh?
2 out of those 11.
So I won't tell you how many I got there. But yeah, I can see that that's very easy to pick up too, and be defined by the DSM. I don't even remember what DSM stands for. Diagnostic something. I don't know. We'll look it up. All right, so DSM stands for Diagnostic and Statistical Manual, which is a manual that has all the diagnostic criteria for a multitude of psychiatric diseases, and they are now up to the DSM number 5. But anyway, that's what DSM stands for. It seems pretty easy to be diagnosed as having an alcohol problem based on these criteria.
That's why I think the numbers of 20% of men and 10% of women will have an alcohol use disorder sometime in their lifetime is probably an underestimate. I think a lot of people do meet the criteria for a disorder but never seek medical treatment for it or are able to get themselves off of alcohol. In 2012, they estimated that 17 million adults in the U.S. aged 18 and older had an alcohol use disorder. So it definitely is a huge problem, and definitely something that we see frequently in the emergency department because we see all the injuries that result of alcohol use. And then in our current homeless population, we see lots of alcoholics coming in that require treatment for withdrawal or a sandwich or just relief from the weather. So alcohol-related conditions also, just to reiterate, affect all social strata. So it doesn't matter if you're rich, poor, or what racial status you have, and affects more than 20% of the patients that we see in the medical setting. And 50% of persons with alcohol use disorder have symptoms of withdrawal when they reduce or discontinue alcohol, and 3 to 5% of these people will have grand mal seizures, confusion, or meet the criteria for delirium tremens. So alcohol definitely keeps us busy in the emergency department, and then the exacerbation that it causes on people's cardiac, respiratory, GI disorders, or even their epileptic seizure disorders. So just as a review, the article goes through quickly that alcohol is a CNS depressant. that causes upregulation of GABA receptors and also inhibits the postsynaptic reuptake of N-methyl D-aspartate glutamate activity. But basically, we just need to know that it's upregulating in order to overcome the effects of alcohol as a depressant. So when you remove the alcohol, you have excessive excitation. And that's kind of defines the alcohol withdrawal syndrome. It's excessive excitation. So you'll have insomnia, anxiety, increased pulse, respiratory rates, body temperature, blood pressure, and we also see the hand tremors and tongue fasciculations as a sign of excess excitation.
So essentially hyper everything.
Hyper everything.
Sounds like a hyperadrenergic state, I guess.
Yeah, because you now don't have any of that GABA regulation because you've upregulated those receptors.
And perhaps for those trainees out there that haven't seen full-blown DTs, these patients can be very sick. They're very agitated. They are delirious, as the name suggests, and they will be extremely hypertensive, diaphoretic, tachycardic, tachypnic. And one of the key features of the hyperadrenergic state is that they will be febrile also. And this is a wonderful differential. It's one of my favorite differentials. So I feel like I have to go through this. Fever plus altered mental status. Most everybody always thinks fever plus altered mental status is an intracranial infection, meningitis, encephalitis, or maybe in an older patient they may have an infection somewhere else and nevertheless develop altered mental status. But don't just think infections when you see fever plus altered mental status. DTs is one of the hallmark causes of fever and altered mental status, and there's a handful of other tox-related reasons for fever and altered mental status. Sympathomimetic overdose like cocaine, anticholinergic overdose, aspirin overdose, particularly in kids, they can get fever plus altered mental status. Don't forget about neuroleptic malignant syndrome or serotonin syndrome. There's environmental causes, for example, heat stroke. There's endocrine causes, for example, adrenal crisis or thyroid storm. And even a stroke that influences the hypothalamus can cause a low-grade fever with altered mental status. So don't just think of infection when you see a patient with fever and altered mental status. Sure, that should be one of your top potential causes, and it would be totally reasonable to go ahead and give all of these patients antibiotics just as a precaution, but you've got to think about the other possibilities as well. Otherwise, these patients will decompensate and have a bad outcome.
The thing that people need to understand, though, is withdrawal can start as short as 8 hours, peaks at 72 hours, and can last for about 5 to 7 days. So a lot of people, or at least a lot of our trainees and people that we're seeing in the ED will think that you can't be going through withdrawal because you just drank today. But did you drink enough to saturate all your receptors, or did you kind of just drink what you had remaining? And then 8 hours after the effects of your last drink, you can start going through withdrawal. So it doesn't last that long. And this all has to do with alcohol has a really short half-life. So that's why withdrawal can set in so shortly. So yes, patients that came to your waiting room drunk at 4, but you don't get to see them until 10 or 12 at night, could actually be going through withdrawal very quickly. The one thing the article goes through that I think really can help us with our identification of these people is to use withdrawal assessment scales. So there's the Clinical Institute's Withdrawal Assessment Scale for Alcohol that was revisited, or the CWA-AR scale. And this scale goes from 0 to 67. When you score the scale, if you have 0 to 8, you're in mild withdrawal. 8 to 15 is moderate, and severe withdrawal is just greater than 15. And those with a score greater than 20 are at increased risk for complications. So you can see there's a huge leeway from 0 to 67. Mm-hmm. I guess the 67s are the ones that are going to add to our 1 to 4% mortality rate. But the score basically assesses 9 areas that include nausea and vomiting, whether you have it to whether it's constant, and that's scored from 0 to 7. If you have sweating, paroxysmal sweats from no sweat visible to drenching sweats, 0 to 7. Agitation, which goes from 0 normal activity for pacing back and forth or constantly thrashing about, would give you a 7. Visual disturbances goes from 0 to 7 too, and that's for hallucinations. Tremors, 0 to 7 for no tremor to severe, even when the arms are not extended. And then tactile disturbances from 0 to 7, going from mild paresthesias to continuous hallucinations of bugs crawling over your skin. Headache's the next area that goes from 0 for no headache to 7, an extremely severe headache. And they have very mild, moderate, severe. So there's definitely a little gestalt in how you're going to rate the score. Auditory disturbances from mild harshness or ability to frighten to continuous hallucinations at 7. And then orientation and clouding of the sensorium is the only one that goes from 0 to 4. And this is that they're disoriented to place or person gives you a 4. Disoriented for date by more than 2 calendar days would give you a score of 3 on this one. So you can see if they've vomited or agitated, complain of a headache, have some hallucinations, you can easily get up there in the score very quickly.
Right. And you only need a score of over 20 to be considered severe withdrawal?
Correct. Severe withdrawal at risk for delirium tremens would be greater than 20. Severe would be anything greater than 15. 8 to 15 is considered moderate.
Mm-hmm. Now, I can never remember all these things, and I know that we have a protocol that incorporates that. The nurses are pretty good about checking in on those things. But for those people out there that don't have a protocol, is there really a benefit of using a score like this versus just clinical gestalt about, you check in and you see them maybe a little tremulous, and so you go ahead and give them benzos? What's your thought about that?
I think because the scores could be so low to be considered severe, I don't know if gestalt's enough, because I think it is under-recognized and people don't treat it fast enough and hard enough. So I think, if you're having any tremors that you truly think is due to alcohol withdrawal, as opposed to those tremors where they just say they're going through withdrawal and they shake their hands for you. But if they're truly going through withdrawal, then you should be hitting them hard with benzos and getting to the treatment. So I think the scoring helps to really quantify how severe they're and add a little bit more objectivity to the scoring system.
Sure. So I guess the tremors may be the horse is out of the barn already by that point.
It's definitely getting there, and I think we tend to minimize too, especially when it's more of our frequent flyers that are coming in, so the scoring system can help us judge how aggressive we should be.
Yeah. And I guess honestly, with as busy as things are, we probably don't actually go and check on those patients too often anyway.
I definitely think could be a habit of just leaving them in the corner, and those are the ones that are there to kind of ruin your day, because things are going to go wrong every once in a while.
I always remember a famous phrase from a famous emergency physician named Corey Slovis, who many of you know. He always said that alcoholics were put on this earth for one reason, and that was to bleep emergency physicians. So you got to really, really be on the lookout. These are patients that are there to burn you. All right, great.
So looking at the CWAS score, some of the background, they say 3 to 5% of hospitalized patients with alcohol withdrawal will meet criteria for severe withdrawal. And again, 1 to 4% of these patients will die throughout their hospital stay. And the deaths tend to be due to either hypothermia, cardiac arrhythmias, complications of withdrawal seizures, or concomitant medical disorders. And those could be electrolyte disturbances, respiratory, cardiac, or GI disease that goes along with it. So next the article goes through and tries to help us predict delirium. Who are those people that are going to get delirium? The things that they've noticed is a CWAS score greater than 15, systolic blood pressure greater than 150, heart rate greater than 100. Well, that's half my emergency department right there. Yeah. But of course, they got to have a history of alcohol use. Somebody that's had recent withdrawal seizures or has a history of prior withdrawal seizures or delirium, older age, recent misuse of other depressant agents, and then those that have a concomitant medical problem. So electrolyte disturbances, thrombocytopenia, and then they mentioned respiratory, cardiac, or GI disease. So we definitely have to do a good history on these people to really ascertain their risk of delirium. The meat of the article, though, goes into the treatment, or I think that's what should be the meat of the article for us. Interesting, the best evidence for treating with alcohol withdrawal comes from 9 prospective studies that were published from 1959 to 1978. This author could not find any additional, more recent studies about how to treat alcohol withdrawal. Now, our goals of treatment are 1, to control agitation, decrease the risk of seizures, and then decrease the risk of injury and death. So our general approach should be the same as we do for anybody with delirium, and that's just general supportive care. You're going to need to frequently reorient them to date, time, and place, so having a clock or calendar in the room, having the lights on.
In the hallway.
Yeah, in the hallway. We can put them on the ceilings. Having a well-lit room during the day and try to turn off lights at night so you don't have the sundowning. Frequent monitoring, which is sometimes what we don't do so well in the ED. Adequate hydration, make sure they have adequate liquids or giving them IV fluids. And then they go and they mention thiamine, which I think could bring us to another whole article, which was a great lit review that S.D. Schabelman and Dick Quo did a literature review looking at glucose before thiamine for Wernicke's encephalopathy.
Yeah, if you give that glucose too early, right, you're going to put them right into Wernicke-Korsakoffs. Well, that's what we've all learned.
That's what we've all learned, but the literature review shows that might not be true. The conclusion by S.D. and Dick Quo after looking at all the literature is that prolonged glucose supplementation can exacerbate or lead to Wernicke's, but that initial bolus of glucose, if you had somebody that was unresponsive, will not harm them in any way. The only people that seem to have gotten harm in the past were those that already had symptoms of Wernicke's when they got the glucose. So these patients definitely could get thiamine and multivitamins to help and replace any of their electrolyte disturbances, but thiamine does not need to be the first medication. It could also be given PO. It doesn't have to be given IV as long as their gut's working. I think the IV vitamins definitely add to cost. And a lot of my frequent visitors probably would be thiamine toxic if it was a fat-soluble vitamin. Thankfully, it's water-soluble and comes out in the urine. Otherwise, they get so many banana bags a year that they probably would be vitamin toxic at this point. But definitely think about thiamine and multivitamin supplementation in these patients. The big thing, though, we got to talk about medical treatment, and I think our first mainstay of treatment is definitely benzodiazepines, and that's what we should be doing, and we need to be doing huge doses of this. It's either very large doses or at least large doses with frequent readministration and reassessment. All too often I see somebody give a milligram of Ativan and I go check them an hour later, and they're much worse for it. I think if we really jump on these patients very quickly, you can actually control symptoms, and they potentially could go to a floor setting where if they actually are going into delirium or DTs, they need to be in an ICU setting and absolutely should not be going to a floor. So the two benzos I think people should be using are diazepam, Valium, or lorazepam, Ativan. Those are the two big ones. I don't think there's really any role for Librium, chlorodiazepoxide, in the ED for people that we really think are going on to delirium tremens. To me, Librium is a great oral drug for those that you know are going to leave the ED and drink alcohol, but you want to give them something that could help them go through withdrawal if they decide to try to abstain. But the problem with Librium is that it takes several hours for it to reach its peak blood levels, and then the half-life of the drug is between 24 and 48 hours. So it takes a really long time to get on board, and then it stays on board for a really long time. So it's not great for us in the ED. We want stuff that's fast-acting, and in this case, long-acting. But we want something that's going to act really quickly, and that's where Valium and Ativan can help us. I personally like Valium because it has a longer half-life, so it helps prevent me from missing the next dose of the medication. Ativan's definitely a much cleaner drug, quick onset, but it has a shorter half-life. Valium even has active metabolites, oxazepam, that helps with the withdrawal symptoms. But if you're going to administer Valium, diazepam, the first dose should be 10 or 20 milligrams intravenously if you think somebody's really going through alcohol withdrawal syndrome.
Now, these are whopping doses, and I think this is part of why a lot of people end up under-treating these patients. You know, normally when we give diazepam, we're accustomed to using it for seizures, and that's, 5 milligrams IV if somebody's seizing, or with the lorazepam, 2 milligrams, maybe 4 or so, but you're talking about really, really mega doses, and the biggest concern is that these patients are going to stop breathing. But you're just using your 10 milligram dose as kind of your handshake with this patient. Here's your 10 milligrams, and this is just a starter dose.
It's just a starter dose. I'll even start most of the time with 20. And
20 IV, huh?
20 IV, and then it's 20 IV every 15 minutes or so until you get the symptoms under control. So really high doses. I've easily gotten up to 100, 200 milligrams with the patient wide awake I've actually told the residents that if they can find that I've over-sedated a patient, I'll buy them dinner. And I did have one come up to me 4 o'clock in the morning and say he's sleeping. And I was like, it's 4 o'clock in the morning. See if you can wake him up. And he woke up in seconds. So it's really hard to over-sedate these patients because their GABA receptors are so upregulated. But you can give really large doses very quickly.
When you're titrating these large doses in, are you titrating for mental status, or is it heart rate or blood pressure? What are you actually titrating for? What are you watching?
So you're watching vital signs, ideally. So all that excitation, their blood pressure should come down, their heart rate should come down, they should stop, they should lose their tremors, their tongue fasciculations. So I think tongue fasciculations are one of the earlier signs and more objective signs that I can pick up, because they could always shake their fingers for me. But I think the tongue fasciculation, so I try to do that, and then mental status. I want to make sure that they're not hallucinating anymore. They should be calm, able to converse with me, but not agitated at all, or flying off the wall responding to internal stimuli. Mm-hmm. So you kind of use all of it to basically the CWAP protocol, score them on that CWAP protocol and try to get their scores down into the less than 8 range. Mm-hmm. So keep hitting them pretty hard if they're up in the high greater than 15 range. Mm-hmm. Oh. But it's frequent reassessments. So even their regimen that they recommend in this article is 10 to 20 milligrams IV.
Of the diazepam.
Diazepam every 1 to 4 hours is needed. That's regimen 1. Regimen 2 is begin with 5 milligrams IV, repeat 10 minutes later. If needed, give 10 IV, repeat 10 minutes later. And then, if needed, give 20 milligrams or repeat 10 minutes later. I tend to just start with a 20 milligrams, give a really large dose, and get them under control as quickly as possible. Because to have us keep going back every 10 minutes, it tends to be a little bit difficult. But these patients really do require a lot of early treatment, and as long as you jump on top of them in the beginning, it can be a really quiet shift. Mm-hmm. But if you don't, and they start really seizing, and then your shift is going to be a lot busier in the end. For Ativan, their first regimen, they recommend 8 milligrams IV or intramuscularly every 15 minutes as needed. And after, if the patient has received 60 milligrams, then you can start going either on a drip, 10 to 30 milligrams an hour, or keep bolusing them in the 8 milligram boluses. Their second regimen is to administer 1 to 4 milligrams every 5 to 15 minutes as needed. And you can even do 1 to 40 milligrams IM every 30 to 60 minutes. And what I would say, though, is if you're going to pick a benzo, just stick with that one. There's no ceiling to the benzos. There's no max dose that you can get to. So if they're still having symptoms, it just means you haven't given them enough. So don't just keep switching, because then you're going to be mixing half-lives and onsets, and it becomes a lot harder. You're going to have more of a chance of having complications with it.
So just stick with one benzo and just take it all the way to the max, not...
Go big or go home.
Yeah. Okay.
Now, they do say you can add other things, like people have added Haldol for some of the agitation. People have added phenobarbital, but phenobarbital has such a sedating effect on it, especially if they're having seizures, the phenobarbital could help. You might wind up actually intubating the patient. If you do feel like you're not having trouble getting control, propofol also works for alcohol withdrawal, and you can adequately sedate them with this, but then you're definitely going to be intubating these patients. And then dexmedetomidine can be used for alcohol withdrawal too. Most hospital protocols would require that the patients be intubated for this, but it does not cause the degree of respiratory depression as phenobarbital. So with good, adequate ICU monitoring, you might be able to sedate them, depending on your hospital protocols, with dexmed and not need to intubate them.
Yeah. So dexmedetomidine is kind of the hot new drug on the scene, and I personally don't have much experience with it. Some of the residents are getting more experience with it, oftentimes on the trauma services. We'll have to talk more about it in the future. We talked about it a number of months ago with Brian Hayes. So keep an eye out for more literature on that, because I guess one of the nice things about that is that if it's not as sedating or doesn't compromise your respiratory status, then it might work out really well. I'm sure it's very expensive, though.
It's a new drug, so definitely the costs are going to be there. But if it can decrease length of ICU stays and aid in hospital discharges, that's where their reps will tell you that it's got a great cost benefit. I, too, have not had to have the opportunity to use it in our emergency department yet, but I know up in the ICUs they're using it a lot now, because it does sedate the patient but makes them arousable, where we definitely all have probably over-sedated patients where they can't arouse as easily. But the big thing is definitely to get on top of these patients. Every 10 to 15 minutes, we should be reassessing them or ensuring that the nurse is, and then dosing another round of benzodiazepines if needed. And then go big doses. Whatever you're comfortable with, double it. So like with a lot of my residents, they only want to get 5 milligrams of Valium, so I at least make them double it to 10. And then they quickly see that they're not getting things under control quickly, so they'll be more comfortable going up higher. But I think you just need to have one or two of these patients to see how much they can tolerate as far as the benzos, and you'll be much more comfortable treating them. But dosing it every 15 minutes, 10 to 20 milligrams of Valium, and then the Ativan, the Razapam, 4 to 8 milligrams will get these people under control. The last big caveat, there's still a lot of people in the medical profession, and it seems to be more the ICU attendings, because those are the ones that we're fighting, that will think that the patient with delirium tremens can just go to a floor bed. And all too often we hear about these patients dying because on the floor they can't push the IV medications. They won't do frequent assessments, so it's every 3 to 4 hours. And it seems like more likely on the floor that these patients are more likely at 1 4-hour assessment not to need their benzo because of their CWAS score, and the next 4 hours later, again, because of that short half-life of some of these drugs, they're going to be back into DTs again. So they really need to be monitored more frequently than every 4 hours, which is what the floor can do. If you do hit them pretty hard with the diazepam because of its long half-life, I tend to have less of these issues, but really push. If you had somebody in DTs, had a seizure, or was really hallucinating, they should be in the ICU for a bit of time. Otherwise, they'll become part of that 1 to 4% mortality rate that we hear about.
Yeah. All right, so great. So recognize these patients early with the hyper state, elevated temperature, heart rate, blood pressure, respiratory rate, diaphoresis, agitation, and oftentimes a mental status change, which is a bad sign by that point also. And then hit them hard, go high or go home.
Go big or go home.
So hit them hard, go big or go home. Big doses of the diazepam or lorazepam. And for those people out there that are not comfortable with big doses like that because you haven't done it before, go ahead and stand at the bedside and just go with 5 milligrams every 5 minutes, and you will see that these patients don't respond easily at all to those small doses, and maybe by the second or third patient that you see with this, you'll be comfortable starting right up with 15 or 20 milligrams of that diazepam. And then think about some of those extra drugs, the Haldol, maybe phenobarb. If you're going to intubate them, propofol seems to be good, and maybe look for more literature on the dexmedetomidine. Play conservative and make sure these patients are going to the ICU because they need close monitoring and frequent IV bolusing of the medications.
This is definitely an area that you need to educate your nurses on, because your electronic medical record is going to pop up an alert that you're giving too big of a dose, and then the nurse is going to come up to you and say what? You want to give all this? So yeah, it's going to take some education on them. Hopefully, if your CWAP protocols are written aggressively, they already have built into it really high doses of these medications, because it's really what's required. There's a report of one patient receiving 2 grams of Valium.
Wow.
Diazepam, 2,000 milligrams in order to get them under control.
That's an Olympic caliber drinker right there.
Yeah. That's somebody that takes their job seriously.
Yeah. All right. Well, great. So, again, the article is published in New England Journal of Medicine, November 27, 2014. Recognition and Management of Withdrawal, Delirium Tremens, and the author is Mark Shukit. And so, Michael, thanks again for getting us through this article.
Thanks for having us.
And we will get you back soon.
Thank you.
All right, well, next up on the EMCast, we have a returning speaker from quite some time ago, Dr. Priya Kupusamy, who finished our emergency medicine residency in 2011, so a few years ago, and is now working out in the community at Laurel Regional Hospital, not too far from Baltimore, seeing all kinds of great stuff. Priya's main academic interest while she was here, and even as an attending attending now has been OBGYN emergencies. And she recently, just 2 weeks ago, gave a fantastic lecture to our residents about preeclampsia. And prior to that, we kind of thought that we knew everything that there is to know about preeclampsia. You know about it for the boards and everything else. But there's actually some new things about preeclampsia that we need to know about, right? So anyway, Priya, let me hand things over to you, and you can give us some of the highlights, and I'll throw some questions out to you based on what I thought I knew about preeclampsia. So first of all, welcome back.
Thanks, Amal. I'm really excited to be here and to talk about this wonderful topic. The reason why I thought this would be an interesting topic to discuss is there's been some new changes in terms of how we diagnose preeclampsia, and this affects emergency physicians as well as OBGYN physicians.
Sure. So now I learned the classic triad, I guess back when I was in probably the third year of medical school, and it hadn't changed in 15, 16, 17, I don't know how many years it's been, up until your lecture. And the classic triad that I and I think most everyone else has learned is hypertension plus proteinuria plus edema. So what's new about that?
Well, I guess if we're considering that triad, we can actually get rid of 2 out of those 3 things and just stick with hypertension. Edema was the first to be removed from the list, primarily because edema is a common finding in pregnancy. Mm-hmm. So we don't want to just look at that as a criteria to rule in or rule out preeclampsia. So while you can still look for edema and have that increase your suspicion for diagnosing someone with preeclampsia, you should certainly not rule out preeclampsia just based on the absence of edema.
So 2 out of the 3 are gone, and so we're now diagnosing preeclampsia purely based on hypertension?
Right. So just to give an overview, chronic hypertension is systolic blood pressure greater than equal to 140 and or diastolic blood pressure greater than equal to 90 occurring before 20 weeks. Gestational hypertension is essentially the same thing in terms of high blood pressure. It's systolic blood pressure greater than equal to 140 and or diastolic blood pressure greater than equal to 90 occurring after 20 weeks. This tends to resolve after delivery, and patients are often normotensive before the 20 weeks. Preeclampsia is essentially gestational hypertension plus new onset severe feature, and I'll talk about that in a little bit. The American College of Obstetricians and Gynecologists created a task force on hypertension in pregnancy, and they spent 2 years reviewing the pre-existing guidelines for diagnosis, treatment, pretty much everything under the sun regarding hypertensive disorders in pregnancy, with preeclampsia being one of the main things that they looked at. And in November 2013, they actually published a report that provided updated recommendations. One of the updated recommendations was the definition of preeclampsia and the criteria that we should be using to diagnose someone with preeclampsia. So this is where all of these changes are stemming from. So going back to the definition of preeclampsia, I had mentioned it's high blood pressure diagnosed after 20 weeks of pregnancy and a new onset severe feature. So if you notice, I don't have proteinuria in there. Mm-hmm. I mentioned before that we've already taken out edema. Now we've taken out proteinuria. We're not necessarily taking it out completely. We're just putting it in this category of new onset severe feature. So it's still there, but we're putting it under new onset severe feature. And basically what that means is to diagnose preeclampsia, you need the high blood pressure plus one of the new onset severe features. It can be any one, but we need at least one. So the way to remember that is the word triple. I love mnemonics, so this is how I remember it. So the T in triple is thrombocytopenia, usually less than 100. If you have that plus high blood pressure in the setting of pregnancy after 20 weeks, you should really be thinking preeclampsia. The R in triple is renal insufficiency. The I is any type of intracranial disturbance. headaches, blurry vision, anything of those sorts, stroke-like symptoms. The P is proteinuria. That's where this fits in. It's still part of the definition, but it's not the end-all, be-all criteria to diagnose it. And then the L is LFT elevation, and then E is edema, but pulmonary edema, not the edema that we thought of before, but edema in the sense of pulmonary edema.
Okay, so preeclampsia is hypertension after 20 weeks, also known as gestational hypertension, plus one of the following features, and you remember any one of those features by the mnemonic triple: thrombocytopenia, renal insufficiency, intracranial disturbances, proteinuria, LFT elevation, and edema in the lungs, pulmonary edema. So, interesting. Okay.
Another thing I want to mention, Amal, is when the American College of Obstetricians and Gynecologists task force published their recommendations, they wanted to emphasize that preeclampsia is a multi-systemic disease. It doesn't just affect one organ system, but rather multiple organ systems, and it can do that all at once. The reason behind this actually takes us back to the pathophysiology.
Okay, I want to give you a basic science pathophysiology alert. If you don't like pathophysiology, just skip forward about 2 minutes or so. But if you can handle it, we'll be through with this in about 2 minutes.
The primary culprit in preeclampsia, if you had to blame something, it's the placenta. That's what causes the symptoms that we see in preeclampsia and ultimately eclampsia. It starts with an incomplete invasion of the trophoblasts, and not to get into embryology, because we all know that wasn't our favorite subject. The trophoblasts are pretty much the cells that go on to become the placenta. This incomplete invasion actually causes impaired remodeling of the spiral arteries within the endometrium. So these arteries, instead of becoming bigger to increase blood flow through them, they actually become narrow and kinked, very tortuous. This then causes underperfusion of the placenta, and the stress that the placenta is under when it's underperfused causes release of cytokines and inflammatory mediators into the maternal endothelium. The endothelium, as we know, lines pretty much every organ system in the body. So whether we're talking about cardiovascular, renal, the liver, the central nervous system, preeclampsia has an effect on all organ systems within the body, essentially. The other thing is that preeclampsia is a very dynamic process. Once the trigger occurs, once you have the incomplete invasion of the trophoblasts and impaired remodeling of the spiral arteries, once that is triggered, it pretty much keeps going. That actual process is constantly changing, and it's constantly evolving, and it's getting worse. So it's a progressive disease. This is why we shouldn't be classifying preeclampsia as mild or severe, because one day it can be very mild, and then the next day it becomes very severe. So we shouldn't pigeonhole anybody into having mild preeclampsia, because they could certainly develop severe preeclampsia or go on to develop eclampsia in a very short period of time.
How short a period of time are you talking about? Like, if you're in the emergency department and you see somebody who meets this definition of preeclampsia, should you be jumping on them right away in terms of their treatment? Is it something that they might go on to develop the full-blown eclampsia within, say, a couple of hours, even if their blood pressure is just a little bit elevated?
So if you can diagnose someone with preeclampsia in the emergency department, you cannot send them home. You have to admit them. They have to be evaluated by OBGYN, placed on MAG, watched carefully, right, because this can happen over a period of hours, even if their blood pressure is just slightly elevated.
Right. So you're not putting them on antihypertensives and sending them for outpatient follow-up at all?
Exactly.
Okay.
Also, in a patient with preeclampsia, the blood pressures can be very labile, so don't be fooled by a slightly high blood pressure, because 1 minute it can be like that and another minute it can shoot up and then come back down, shoot back up again. So blood pressure can be changing in someone with preeclampsia.
Sure, so it bounces around pretty much. All right, good. Now, you talked about some of the diagnostic criteria. Is that all that's required to make the diagnosis of preeclampsia?
From the emergency department setting, the important parts in the diagnosis, of course, are vitals, physical exam. Vitals, you're looking at that blood pressure. That usually is the first tip-off for an emergency medicine physician that they should be looking more into it rather than ignoring the elevated blood pressure. Don't just be falsely reassured that elevated blood pressure is due to pain or stress or something external. Be very cognizant that in a patient who is pregnant with elevated blood pressure, you should be taking the next step to look into the possibility of preeclampsia. In terms of physical exam, you want to do a complete neuro exam. Of course, listen to the heart, listen to the lungs. Do a visual acuity exam, especially if the patient is coming in complaining of blurry vision. A lot of times, blurry vision may be the only symptom that they're having in addition to elevated blood pressure, and you can see how preeclampsia is easily missed in these situations. In addition, you want to get certain labs like CBC, CMP, coags, as well as LDH to check for hemolysis. You can also get a D-dimer level, fibrinogen. Don't forget about the urinalysis. Even though I said proteinuria is only part of the diagnosis now, it's not one of the major criteria, it's still important. It's still one of the new onset severe features that a patient can come in with, and if they have proteinuria in the setting of hypertension, then yes, they do have preeclampsia. So you do want to get that urinalysis to check for proteinuria. But understand that the urine dipsticks that we do in the emergency department, they can be falsely negative, primarily because protein levels can vary throughout the day. So depending on when you check it, it may not meet the threshold of the 1+ proteinuria that's needed to diagnose someone. So if you don't see proteinuria, don't rule out preeclampsia. If you see it, however, yes, go forward with your suspicions. Another important diagnostic tool that's become popular in the last few years is a uric acid level. It's thought that uric acid can alter endothelial function. So it's not just used for gout anymore. It's actually a very important diagnostic component for preeclampsia. It can aid in the early diagnosis of the disease. It's not only diagnostic, but it's also prognostic because it can reflect the degree of the placental cell destruction as well as the severity of the disease. So any level greater than 5 is considered positive. It's considered abnormal. So it's diagnostic in that sense, but also prognostic because the higher the number is, the more severe the disease. If you call OBGYN for a consult on a patient who you're worried about preeclampsia in, they will ask you about the uric acid level. So get it early.
Yeah.
It'll help you and it'll help them.
All right. I don't think I normally think about uric acid levels for these patients, but maybe I'll look smarter the next time I call a consult and have that level for them. So now, if the uric acid is normal, does that help rule it out then? Is it that diagnostic?
If the uric acid is normal, then I would put it as part of the bigger picture. So if they're coming in with other symptoms and their blood pressure is high, then you're still worried about preeclampsia. So you should still move forward in terms of the further evaluation, OBGYN consult. So I wouldn't necessarily rule out preeclampsia if the uric acid levels are negative.
Okay, so I think I've got a handle on diagnosing these patients, but what about management? I know they're not going home, they're going to be admitted to the hospital, but what should we be thinking about doing while they're in the emergency department before they get upstairs?
Right, so with management, I want to reiterate that preeclampsia is a dynamic, progressive disease. So the treatment and the management of preeclampsia may reduce the risk of serious complications, but the underlying process of inflammation and endothelial dysfunction will continue to progress. So I want you to remember A, B, C, D, E, F. So we got the ABCs, right? Airway, breathing, circulation. D is dextrose. Check a finger stick. If a pregnant patient comes in with stroke-like symptoms or altered mental status, yeah, she could be having a stroke from preeclampsia, but she could also have a low glucose and needs an AMPA D50.
Sure.
So always check a finger stick. And so the D is for dextrose. E is, of course, for exposure. And F is something that Ken Butler taught me, and that's to remember fetal heart tone. So if a patient comes in and they're male, you're done. You don't have to really wonder if they're pregnant. But if a patient comes in and they're female, and especially if they're altered, not able to talk to you, remember the F in A, B, C, D, E, F, because it will get you to think about whether the patient could be pregnant and whether you should be thinking about pregnancy as a cause for the symptoms that they're coming in with. And you can simply ask them for a last menstrual period and check a pregnancy test, or if they're not able to give you this information and family's not around, just put an ultrasound probe to their belly and try to see for yourself if they're pregnant or not.
Sure.
The other important thing, of course, is fetal monitoring, getting an early OB consult, and another thing you have to consider is blood pressure control and monitoring. So if they come in and they meet the criteria for preeclampsia, and this is somebody who's not going home, who's going to be admitted, and their blood pressure is severely elevated, you have to start putting them on medications to try to control the blood pressure. Now remember that blood pressure elevations must be persistent. If somebody comes into the emergency department, you notice that their blood pressure is high, just like in non-pregnant patients, in order to diagnose someone with having hypertension, they have to have 2 elevated blood pressures within a certain period of time. So in the past, with preeclampsia and disorders of pregnancy, in order to diagnose somebody with hypertension, you had to have 2 elevated blood pressures measured at least 6 hours apart. That's since then been changed to 4 hours apart. So if you can document elevated blood pressures 4 hours apart, then you can say that this person has hypertension. The other thing is that if a patient comes in and your suspicion for preeclampsia is extremely high and their blood pressure is extremely high, don't wait the 4 hours. You can in fact continue with your management of the patient if you've diagnosed them with preeclampsia, as long as their blood pressures continue to be severely elevated for 15 minutes. That's all you need to continue, because waiting that 4 hours can actually adversely affect the patient.
Yeah, and it's a bit impractical in the emergency department also, so 15 minutes is reasonable.
If it's severely elevated.
Yeah, okay.
The other thing is you want to avoid, of course, rapid reduction, so you want to follow the same rules that we would follow in non-pregnant patients with elevated blood pressure or severely elevated blood pressure, and avoid the rapid reduction. You also don't want to ignore isolated systolic hypertension and just attribute it to pain and things like that, because a lot of studies have shown that in women who, with preeclampsia, who progressed to have strokes, they actually presented with isolated systolic hypertension as opposed to isolated diastolic hypertension. I know that we always think of isolated diastolic blood pressures as being a harbinger of something bad, but don't ignore isolated systolic hypertension, especially in cases of preeclampsia. The most common medications for the management of blood pressures in preeclampsia are labetalol and methyl-dopa. Now, the good thing about labetalol and methyl-dopa is it's safe in pregnancy. You can give it to breastfeeding mothers in cases of postpartum preeclampsia. Methyl-dopa, unfortunately, only comes in a oral form. this is a good medication for patients to be on for outpatient control of blood pressure. Labetalol is a good choice for inpatients because you can give it both IV and oral. And then second-line agents are nifedipine and hydralazine. We tend to steer clear of hydralazine only because it has a lot of adverse effects. It can cause pretty significant tachycardia. And then, of course, one of the biggest components of management of preeclampsia is magnesium. Magnesium is great because it works on the smooth muscle cells and it causes vasodilation, and it's a good medication to prevent the progression of preeclampsia to eclampsia. So for a patient that you'd like to start on MAG, you want to give 4 grams IV over 15 minutes or over 5 minutes if they're actively seizing, and then you want to infuse as a drip 1 gram of magnesium per hour for 24 hours. And you want to maintain MAG levels between 2 and 4. The important thing while somebody's on MAG is you want to check for magnesium toxicity. So you want to look for delayed deep tendon reflexes, decreased urine output, decreased respiratory drive, something that we've all had good practice with while doing our OBGYN rotations as a med student. And if the patient does develop magnesium toxicity, then calcium gluconate would be the choice to reverse that.
All right, I want to share with you an anecdotal story, and I don't want to change anyone's practice necessarily based on one anecdotal story, but back when my wife was pregnant with our first child, she had preterm labor at around 32 weeks or so, and they wanted to slow down the labor, so they gave her the standard 4-gram dose of magnesium, and I think it was planned to go in over maybe about 10 or 15 minutes or so. Now, my wife is only about 100 pounds, and when she was pregnant, she gained maybe about 10 or 15 pounds, so she didn't gain a whopping amount of weight. She probably wasn't suitable for the standard dosing of magnesium, 4 grams over 10 or 15 minutes. And within the first 5 minutes of this bolus of magnesium, she dropped her blood pressure to the 60s. She got pale, diaphoretic, ashen, started having nausea, vomiting, bradycardic. She just looked awful. And I'm standing there in the room saying, give her calcium, give her calcium, give her calcium. And the OBGYN wasn't there. It was just the nurses who'd probably done this 1,000 times for people that are at least twice her weight. They didn't know what to do. They at least turned off the magnesium, and thankfully, within just a few minutes, she started feeling a little bit better, plus a little antiemetic made her feel better. But holy cow, that gave me a healthy respect for what magnesium can do. I mean, we give magnesium to everybody who's really sick with asthma or with COPD. And a lot of cardiac patients that are a little hypomagnesiemic, and we give it very slowly, just 2 grams very slowly. We give it to a lot of alcoholics. But if you're going to push magnesium any faster than with those other groups of patients, especially larger doses of magnesium, be very careful and have a healthy respect for magnesium, because if it runs in too quickly, and that may happen on relative terms if you're dealing with a lightweight person, then you can induce bradycardia, hypotension, everything bad. So be respectful of magnesium. Now, I'm not telling you not to use 4 grams, but personally, in somebody who's 100 pounds, I would not give 4 grams over 10 or 15 minutes. I would run it in a little bit slower than that for sure. And I would have calcium very close by. Respect the MAG. All right, Priya, back to you.
From the American College of Obstetricians and Gynecologists task force, their report did not have very many changes in terms of magnesium's involvement in preeclampsia as a treatment agent.
So still tried and true and still fairly recommended in all the guidelines, the magnesium. Right, and then just to recap, in terms of blood pressure, you're going usually with labetalol or methyldopa. Labetalol, I think all emergency physicians are pretty comfortable with. Then hydralazine and nifedipine may be more second line. Don't go crazy about lowering the blood pressure with rapid reductions, but do lower the blood pressure, especially if it's severely elevated.
We also know that the definite ultimate treatment to preeclampsia and eclampsia is delivery of the fetus. You can also think about management in terms of the gestational age as well. So if a pregnant woman is greater than or equal to 37 weeks gestation, so she's full term, then yes, the treatment is to deliver as quickly as possible. If a woman is between 34 and 36 weeks gestation, then you do ultimately want to deliver the fetus, but you want to do expectant management as much as possible until they get to term. But the minute the patient takes a turn for the worse, gets new symptoms, or just becomes worse, you want to go ahead and deliver the fetus. And then in terms of viability to less than 34 weeks gestation, you want to do expectant management just like between 34 to 36 weeks as much as possible. Again, if things take a turn for the worse, then you do want to go forward with delivery. The one thing to add with this gestational age range where viability to less than 34 weeks is you want to start steroids in order to assure fetal lung maturity. And ideally, you would want to have steroids going for at least 48 hours before delivery. Now, if the patient becomes severely ill and it's been less than 48 hours, then you should go ahead and proceed with delivery. But if you can hold out for that 48 hours, that would be great. If you can hold out for longer, that would be even more wonderful. But again, the minute the patient takes a turn for the worse or gets new symptoms or worsening symptoms, OBGYN doctors will push towards delivery.
Sure.
And then another category that's just as important as all the other gestational age ranges that I mentioned is the postpartum. Pre-eclampsia can be diagnosed up to 6 weeks postpartum. So just because a patient already had their baby doesn't mean that they're in the safe zone in terms of preeclampsia, eclampsia. Postpartum preeclampsia tends to occur in the first 48 hours, but really it can be diagnosed or first occur up to 6 weeks postpartum. You don't have to have any episodes of hypertension during the pregnancy itself. And in one particular case, they reviewed 89 cases of eclampsia, and they found that over 30% of cases developed in the postpartum period, and of those, only 5 cases were diagnosed during the pregnancy itself. And also, there's lots of studies that have shown that headache is one of the most common presenting symptoms with postpartum preeclampsia, so something to look out for in addition to vital signs.
So when that patient comes in with a headache, it may not just be from lack of sleep from having the new baby, but think about preeclampsia as well.
Exactly. And in terms of management, one part's done. The baby's already delivered, so that part's good. But you have to now take care of mom in that you want to control the blood pressures and you want to start her on MAG and make sure you try to prevent the progression of preeclampsia to eclampsia as much as possible.
Now, Priya, if I have a patient in the emergency department who's got hypertension, and let's say I go through everything and she just has hypertension and doesn't have the formal diagnosis for preeclampsia based on what you've talked about, what do we do with those patients? Do they need to come in also, or what do we do?
So patients with isolated elevated blood pressure with a negative workup can potentially go home. Again, I say negative workup, so that means you've checked a urinalysis, you've checked labs, you've checked a uric acid level, and they have to be asymptomatic. So somebody who comes in with elevated blood pressure in their 22nd week of pregnancy complaining of a headache deserves an OBGYN consult and possible admission for further evaluation, because they're coming in with one of the criteria, the severe new onset feature, which is headache would fit under intracranial disturbance. So they have to be asymptomatic, so no new onset severe feature, and they have to have isolated elevated blood pressure with a negative workup in terms of labs. And those patients should get very close OB follow-up, so that should also go into your thought process for possibly discharging a patient. And you also want to explain red flags to watch for. Patients should not go home thinking, okay, well, I don't have preeclampsia, I'm okay. They should go home thinking, I could develop symptoms and I could still have preeclampsia, so what symptoms should I watch for? have that discussion with the patients and make sure you document it in the note as well.
Right. All right, great. Well, this has been very helpful information. You said you have a couple of pearls that you want to leave people with, the most important pearls. How's that?
All right. So 3 things I just want you to remember about preeclampsia. Remember that it's a dynamic, progressive disease that affects multiple organ systems. Remember the new definition of preeclampsia. You don't have to have proteinuria to get that diagnosis. Think about the triple mnemonic, and all they need to have is elevated blood pressure and one of those new onset severe features to earn themselves the diagnosis. And third, remember the importance of a uric acid level as part of your workup. It's both diagnostic and it's prognostic.
All right, great. Well, Priya, thanks so much for bringing us up to speed on the new recommendations and new guidelines for preeclampsia. So hope to get you back soon.
Thank you for having me, and it's been really fun talking about this.
All right, well, that's going to do it for the March 2015 EMedHome EMCast. And my thanks once again to Drs. Samara Tuweld, Michael Bond, and Priya Kupusamy for bringing us up to speed on topics this week. Also, don't forget about the Resuscitation Conference in Las Vegas, May 1st through May 3rd, www.resuscitation-conference.com. I look forward to talking to all of you next month. Until then, stay warm. Bye for now.